All right, everybody, happy Thriving Thursday. We have been talking all about emergence techniques and stuff like that this week, as along with how kind of the anesthetics work and putting your brain to sleep. Because in order to really understand how patients wake up from anesthesia, we have to understand what we're doing to them while they're in anesthesia and putting them to sleep. So I'm going to talk about the brainstem a little bit and try to just kind of big picture view, tie everything together, and then look to Facebook tomorrow, and I'm going to have some awake and deep emergence checklists, some of the things to watch out for, and some of my little tips on emerging safely. All right. So I first just want to be, let's just go ahead and just back it up. So when a patient is under general anesthesia, we actually are altering their neuron activity. Like we're literally changing the neuron activity in their brain. And what happens is people, there's been tons of research done on people's brains under anesthesia. And as you're looking at the EEG of the brain oscillations that are on the EEG while a patient's under general anesthesia, we're not only altering how the neuron is working, but we're also altering how brain regions communicate with each other. And when you change that up, you actually get behavioral changes. And that can go on a whole other, tangent of, some of the cognitive issues that can happen post anesthesia, delirium, etc. But anyways, big picture is when you are inducing anesthesia, giving these patients drugs, you are altering their brain chemistry and how these neurons are actually working. And then we're going to dive into the brainstem stuff. So to understand anesthesia and what we are doing to these patients who are undergoing surgery, we got to understand how the brainstem works, right? I think we all know how important that little stem is right at the back of your head. But it's basically like a relay center. So it's sending information from the cerebrum to the cerebellum to the spinal cord, and it's responsible for basically a lot of the autonomic functions of our body. So our breathing, our heart rate, wake sleep cycles, temperature, coughing reflexes, swallowing, and 10 of the cranial nerves are actually from the brainstem. I believe it's number 3 through 12 come from there. Okay, so super important. We already know that. So what does it have to do with anesthesia? Well, what are we doing to patients, right? So those listed there, those are the 5 things that basically you are doing to patients when they are undergoing surgery and having anesthesia. So at first, we want them to be completely unconscious, right? We don't want them to have any awareness, no sensory awareness of what is going on around them. We also want them to be amnestic. We don't want them to remember anything that's happening, be able to recall anything, right? Because having surgery is a traumatic, stressful experience. We also want to provide them with analgesia. No pain is nice. Akinesia, we don't want them to move. And obviously, we use paralytics for that. But also if you turn up those volatile anesthetics, there actually is some muscle relaxation, and that has to do with the GABA receptors in the brain as well. So we don't want them to move for surgery. And we also want to keep them physiologically stable. So, using ephedrine and phenylephrine and, tweaking what we're doing to keep the heart rate, the blood pressure, all within their baseline, all within safe parameters, as well as using the ventilator. Right. So basically, when a patient is under anesthesia and we are taking them out of consciousness, we are messing with the functions of the brainstem, right? Like that's why your job is so important. And that's why you are working your little tails off, learning how to give anesthesia in a safe manner. All right. So I wanted to break this down in this slide here and just talk about kind of the stages of anesthesia. And we can't talk about them without understanding Guedel's stages of anesthesia. So putting someone to sleep, right? So inducing or induction of anesthesia. I think I had a Thrive video before. We're talking about it's almost like comparing to like pilots, right? Taking off the plane and then landing the plane. So we're taking off, or in stage 1, that's the amnesia and the analgesia phase. So that's when you get your patient on the table, you got all their monitors hooked up and everything, drugs to loss of consciousness, right? So we're pushing the drugs to loss of consciousness. That's that stage 1 anesthesia, right? We're just beginning, we're just inducing it. Then that takes us into not really the maintenance phase, but I kind of put that in there, just so you could see the phases of anesthesia up top. But then they move into stage 2. So you've pushed your probe, your patient's loss of consciousness, they've lost their corneal reflex. Now they have to kind of go through this pass-through phase, right? So this is the delirium or the excitement phase. This is like, this is where some risk can happen. You never want to really stimulate the patients here, like make incision or anything like that. And you also don't want to ever extubate in this plane. And their eyes, their eyes are all funky and diverge and everything. But that's like stage 2, the excitement stage of anesthesia, the pass-through stage. And then where we want them to be is we want them to be in the surgical anesthesia stage, which is stage 3. Okay. And this is where you're maintaining and you are flying this plane of anesthesia. Now there is stage 4. That's kind of like leads into death. So we want to like keep them in stage 3. Maybe, you know, we might touch back to stage 2, but we want to keep them in stage 3. We don't want to go into stage 4 because that's when literally their brainstem, everything is like toast and not working. So this is where you're kind of in that maintenance phase and you're tweaking everything because they have now lost the ability. They're completely unconscious and they don't really have the ability. They've lost their airway reflexes and they don't really have the ability to, manage their hemodynamics as best they can. I mean, some can, but they're also, you have to think about their comorbidities, their cardiac history, et cetera, et cetera, et cetera. So anyways, so that's kind of the plane of anesthesia. Induction, then we maintain induction. We go stage 1, stage 2, stage 3. Stage 3, we get kind of is in our maintenance phase. And then we go to emergence, which is waking the patients up. And bad things can happen in emergence. Like the biggest thing that you don't want to happen is have to re-intubate the patient because that can lead to MIs and other big problems. So basically emergence is this passive or gradual return to consciousness, right? We're landing the plane. We don't want them to fail the emergence test, right? And basically it's when they're optimized physiologically and pharmacological conditions are also optimized as well. So when you are waking your patients up, what are you looking for, right? It all goes back to the brainstem. What is the brainstem doing? We just said we want them to be physiologically intact, right? So if their brainstem is back, usually their vital signs stable out. If you've been struggling with hypotensive during the case, you start getting the gas off, you start waking them up, you find that their heart rate and usually their blood pressure begins to stabilize, right? And then before you pull the tube, we're not going to talk about deep extubation here. I'll have some notes on it in Facebook, but once we want to get them back to that awake phase, right? We want to get them back to that phase where I know their brainstem is back. So what are we looking for, right? We're looking at their brainstem is back. So they kind of start to grimace. You're going to see them swallow. They kind of start coughing on the tube because now they realize that there's something there, right? Those are all the things that you are looking for, letting you know that the patient's brainstem is back, right? We're bringing them back into consciousness and you can safely pull that tube and you know they're going to fly on their own. Okay. So I hope that was helpful. I briefly just kind of touched on some things. I like to be quick, give you guys a big umbrella picture view of everything. If you have any questions, obviously, please let me know. That's what I'm here for. And look to Facebook in the next 24 hours and I will get some more information up there for you all. Okay. All right. Happy studying, cheering you guys on. Have an awesome rest of the week and into the weekend. I'll talk to you guys soon.